I'll just bring that.
Okay, sir, promote.
Thank you.
Thank you, Dr. Anupam. Good evening, Dr. Vasudev Srinivasan. Good evening, sir. Dr. Tej Mathu was there in Chennai today.
Good evening, sir. Dr. Srinivasan. Good evening.
Good evening.
Good evening, sir.
Dr. Tej Mathu was there. I talked to him. I'm in
Oh,
USA for the
acha.
last 6 months.
Okay.
But he had come to this thing, then it seems he was mentioning because we conducted the workshop, in Pondicherry.
Oh, great. So please
Yeah.
request him to come to Delhi also. We'll meet him, sir. Can we start?
Yes, sir.
Okay, right. Thank you very much. It's a pleasure to have all the stalwarts of nephrology here also, and with senior members. Dr. Srinivasan has joined. Dr. Anupam Sajdev is there, and we have already have about 75 participants. And it's my pleasure to introduce Dr. Shashikiran KB. Dr. Shashikiran is a present designation is assistant professor and head of the in charge of the unit, and his affiliation is to the Institute of Nephrology, INU, in Mysore, Karnataka. And he has done his pediatric nephrology and first to start pediatric nephrology services in Mysore. He is the secretary of IAP Karnataka State Branch this year, 2024, and was the secretary of IAP Mysore branch in 2021. He has a lot of publications to his credit, and national and international journals in pediatric nephrology. And we would have him as the moderator of the session today. And it's my pleasure to welcome Dr. Shashikiran. Welcome, Dr. Shashi, as a moderator. Thank you very much. And I think you can introduce Dr. Anuba as a chairperson. Thank you.
Thank you so much, sir, for the introduction. At the outset, I thank the Institute of Child Health, Sri Gangaram Hospital, New Delhi, and IAP Delhi for giving me the opportunity to be a moderator in this very important session. We all know UTI is just not another infection, because it has serious consequences in very young child, which can lead to sepsis and even lead to mortality and severe morbidities. And if not appropriately treated, can lead to long-term consequences, including proteinuria, kidney disease, hypertension, and even renal failure. So to discuss on this very important issue, we have had a lot of change in practices in the last decade or so. So to discuss about all these things and to update on this, I request Dr. Anubha Srivastava Madam to chair this very important session. Madam is Professor and Head of Department of Pediatrics at MLN Medical College, Prayagraj. Madam has done her MD Pediatrics from Postgraduate Institute of Medical Science, Rohtak. She has her ISPN Fellowship in Pediatric Nephrology from prestigious AIMS, New Delhi. Madam is currently in charge of Pediatric Nephrology at her department. She has also served as Central Zone Coordinator of ISPN. Madam has been a state mentor for SNCU services. She also has served in various capacities like organizing secretaries of CME, national quiz, social awareness programs related to pediatrics, neonatology, and as well as nephrology. To her credit, she has multiple publications in national and international journal, and she has been a reviewer to various journals, including our own prestigious Indian Pediatrics. With this brief introduction, I call upon Madam to chair the session and take it forward. Thank you.
Thank you, Dr. Shashikiran, for your kind introduction, and welcome to this discussion. It's my great honor to introduce Vasudev sir for this speech on UTI, which is a very pertinent topic not only for pediatricians in general and pediatric nephrologists in particular. And in recent time, we have come across the updated guidelines for UTI management, on which sir will be enlightening us today. Sir needs no introduction, but still I would like to highlight some of sir's achievements. Sir is presently senior consultant, pediatric nephrologist at Indraprastha Apollo, Max and Holy Family Hospitals, New Delhi. He had been national vice president of IAP 2020, and he is vice chair at Pediatric Kidney Foundation and visiting faculty at NCW USA. Sir has been editor-in-chief for IAP textbook on pediatric nephrology, editor for algorithms in pediatrics, and editor for IAP textbook of radiology. Sir has been recipient of V. Balagopal Award of IAP Best Paper, and also for Best Paper Award from IAP Delhi. Sir has been awarded the Young Scientist Award for Department of Science and Technology, and is recipient of Oration Award 2020 for and in also at Bihar Pedicon in 2019. To Sir's credit, there are over 50 publications in national and foreign journals, and has numerous chapters in various books, and has delivered already more than 1,000 talks in nationals and international conferences. So we are lucky to be audience to yet another talk by Sir on this very important topic. So I hand over the talk to you, sir.
Thank you.
Welcome.
Thank you very much, Dr. Anubha, for a very kind introduction, and also thanking the ICH office and the IAP office for hosting today's meeting and arranging the meeting. It's my pleasure to be with you all. So with the permission of chairperson and moderator, can I share the slides and then start the talk? Right. Is it full screen now? Can you see the full screen?
Yeah, sure, sir.
Okay,
Yes, sir.
fine. So I can begin my talk, and as already highlighted, I'll be talking on the urinary tract infections in childhood, and mostly on the revised guidelines, but I'll also apprise my pediatric friends who are on the platform about the other features of UTI, and then go on to the revised guidelines. So as already highlighted, that urinary tract infection is a very common bacterial infection in childhood. And I would say that I was also surprised to learn that it is second only to the respiratory tract infection. And my point was that we see so many respiratory tract infections day in and day out in our clinical practice and OPD and IPD, but are we really seeing so many UTIs? If we are not seeing, that means we are missing a lot of them. And UTI is fairly common. 2% of the boys and 7% of the girls would develop at least one UTI by 7 years of age. And why is the diagnosis often missed? Because the symptoms are very non-specific, and that's why we would miss, and we would see how the non-specific symptoms have to be kept in mind to diagnose UTI. And the risk of scarring is the main thing where we are worried about the urinary tract infection. Now, if you see this slide, any child who has got, these are all subtle signs. Fever without a focus or sepsis, we should think of UTI. If there's fever which is like after 3 or 4 days, not settling, not like viral, I think we should think of UTI and get an examination done. If there's a newborn who has got hypothermia or jaundice, which is prolonged, again, we should think of underlying urinary tract infection. If a child has got unexplained vomiting and diarrhea, which is so very common in our day-to-day practice, but any child who is coming with recurrent vomiting and diarrhea for no rhyme or reason with a good hygiene, think of underlying urinary tract infection. And if a child has got failure to thrive, this is again one of these symptoms of UTI, and we should think about it. And it's only very, very uncommon where we don't need to even discuss and know about it, that the child has dysuria, urgency, frequency. I think the symptoms itself is speaking about it, but you will not always find these symptoms to detect UTI. So you have to look for other subtle symptoms where UTI, underlying UTI can be present. Now I'll start with a case. This is a 10-year-old girl who was evaluated for short stature. Why was she evaluated? Because her 8-year-old brother was taller than this child. And that is what the parents got worried about it, that what is happening. Her height was less than 3rd centile. And when the blood pressure was noted by the pediatrician friend, it was 160 by 100, which was more than 95th percentile for this child. So this child was basically referred to an endocrinologist, a friend who had seen this child, and once he saw the blood pressure is high, he was little concerned that probably it may not be an endocrine cause. The routine examinations which he got done, the blood urea was high in this child, 60 milligrams, and the serum creatinine was about 2.5, which was way higher than the normal. So this child immediately was sent to us that probably this is some other renal problem which is leading to a short stature, and it's not an endocrine cause or a nutritional cause. When an ultrasound was done, there was bilateral small contracted kidneys, loss of corticomedullary differentiation was seen in this child, and probably we were very certain that there is something abnormal going on in this child, and the kidneys are already contracted and they are already damaged. So at this stage, further investigations were done. A DMSS scan was done, which showed bilateral scarred kidneys. And to rule out reflux, when we did an MCU, there was a bilateral VCUG was showing a bilateral reflux in this child with the bilateral scarring. So what was happening actually in this child? When we retrospectively asked the mother, the child had multiple episodes of fever, which was possibly urinary tract infections, which were haphazardly treated and not evaluated. And this all resulted in chronic kidney disease with scarred kidneys and deranged kidney functions due to irreversible kidney damage and hypertension. So my dear friends, I think these are the cases which are learning points that we don't have to miss these children, and they do not need to come to us at 10 years of age with scarred kidneys. If they're having recurrent infections, recurrent fevers, not growing well, I think we should suspect urinary tract infection in these children and start evaluating early rather than delaying the diagnosis. So that was a learning point to start with. So whenever we have a child who's suspected of UTI, the initial evaluation, of course, apart from a general physical examination, please do take a blood pressure, and that too with a proper size cuff. So here I would suggest that all of us would have an adult size cuff in our clinics, that is a 5-inch cuff size. If you attach a 3-inch cuff size to that 5-inch, instead of 5-inch cuff size, you can measure the blood pressure in most of these children from 2 to 18 years of age. And you do not need to keep all the sizes of blood pressure cuff size from 1 to 5 inches size. And if you can just have one more cuff size, it can suffice. And also, if you can have the other sizes, it's very good. But otherwise, you can manage with 3-inch cuff size in most of these children. Then we need a urine examination, routine and culture. And some of these sick children would need blood counts, kidney function tests, CRP as and when required. And younger infants and sick child would require a blood culture also. So these would not be required in all these children, but in specific children who are very sick. So another thing which I want to, when you are seeing the general physical examination, always try to see the genitals of the child. And I would say that we should differentiate between the physiological and the pathological phimosis in these children. So any child who is below 2 years of age and has got appearance like this, we do not need to pull the prepuce back, which is mostly the habit of our, at least in North India, the grandmothers would keep putting oil in every possible hole they find, and whether it's an ear, it's a nose, it's a umbilical area, vaginal or preputial area, and they would try to pull the prepuce back, and this is what happens. There's a scarring and the prepuce would be pulled back, and that can lead to scarring of the prepuce and again adhesions. So if a child has got after 2 years of age an opening like this, where you can see the meatus, you do not need to pull it back. It's physiological, and automatically after a certain age, this would open up and the glands would be visible, but don't try to push it back, and always instruct the mothers and especially the grandmothers that don't try to pull it back. Then second thing about the girls, we often forget to see the genitals in the girl, and sometimes there may be labial adhesions which may be causing recurrent urinary tract infections, and a simple treatment of putting an estrogen cream for a few days can separate the labial adhesions, and the child can be saved from recurrent antibiotic courses if the child has got recurrent UTIs. So it's important that we must see the genitals also when we are doing a physical examination in any child who is suspected to have UTI or any renal problem. Now, once we talk about UTI, first and foremost thing is the collection of urine, and collection of urine is important. There are various ways. Sometimes we apply bag to the genitals where urine is collected, but it has got a very high contamination rate and high false positive results. The culture is sent. So positive cultures are not very important when we are collecting a urine bag specimen. They should be discarded. It is only useful for ruling out UTI. That means if the bag specimen is negative, that means we are not dealing with UTI. And if the bag specimen is positive, do not pay any heed to it. Bag specimens are just good for routine examination, seeing the volume, seeing the specific gravity, and routine examination, or for general physical examination of the urine, but not for culture. Most of the time we need a clean catch specimen, and this is a non-invasive, and in toilet trained children it's not very difficult. The child can be asked to void the urine, and sometimes it's difficult in a non-toilet trained children. And before that, we must always explain to the mother to collect the urine. Proper collection means that the child's genitals have to be washed with plain water and not with any soap, or antiseptic should not be used. And after that, the child starts passing urine, and we collect a midstream urine. So 2-3 simple steps have to be explained to the parents before the collection of the urine, that it should be preferably a morning sample, or in daytime, if the child has not passed urine for 2 to 3 hours, we can collect a daytime specimen. But before that, wash the genitals with the plain water and take a midstream urine. And in small babies where it's difficult, the child cannot void on command, we have what we call as voiding stimulation. That means it's a quick wee method. We apply a cold sponge on the bladder area, and applying the cold sponge, suddenly the bladder will contract and the child will start passing urine. But before that, the precautions of washing the perineal area should be there. And one person cannot do it normally, so we have another person with the bottle ready. And once the child starts passing the urine, you can leave the first few drops and then collect the urine without touching the private parts. Occasionally, we need a catheter sample or a suprapubic sample in the wards in admitted children where it's not possible to collect by midstream clean catch. Again, transportation of sample is very important. After the sample is collected, it should be immediately transported to the lab, and it should be plated within an hour. But sometimes the child has come at an odd hour and we cannot send the sample. That time the sample should be stored at refrigerator at 4 degrees. It can be stored for next few hours, and send the sample as early as possible to the laboratory once the sample has been collected. Now, once the sample has been collected, the changes which the changes which we have made in the recent guidelines, we were always relying on urine routine microscopy. And sometimes the microscopy sample is sent and it is lying in the lab for a few hours, and the report will come by evening. So another very good test which is replacing the microscopy as a first line test is the urine dipstick method. Dipstick has got 2 good enzymes, leukocyte esterase and nitrite, and a combination of both these as a first line screening test for UTI can be utilized. If both are positive, it has got a very high sensitivity and specificity. And if they are positive, then you can send the culture and start empiric antibiotic before the culture report comes, if both of these are positive. And once the urine is sent, then collected, we can send for microscopic examination a freshly voided sample as an alternative to dipstick for screening UTI. But sometimes it's not possible to send a fresh sample every time, so we would rely on the urine dipstick, and they're very simple, easy to do. It's a bedside thing. You can do it in your own OPDs, in clinics, or at bedside in the hospital, and immediately the result can come within few seconds. And then urine microscopy is sent, and if there are WBCs, which are often labeled as pus cells. That's a misnomer. There's nothing like pus cells. You see pus, but there is nothing like pus cells. They are actually WBCs. And in a centrifuge specimen, which most of the labs would do, if there are more than 5 WBCs per high power field, they are significant. And of course, if you have a microbiologist in-house, he can see a fresh urine sample and bacteria can be also detected. So all in all, if we have a leukocyte esterase and nitrite positive and a microscopy is positive with WBCs, you are more or less certain, and it has got a very high sensitivity and specificity for detecting UTI, and you can send a culture and start an empiric antibiotic pending the culture report in these children. So that is the one change, first change which is made, is that instead of relying on microscopy, now we are relying more on the dipsticks, and they are very easy to do. Now, once the urine culture has been sent, we must know how to interpret the result. If it's a suprapubic sample, then 10 raised to the power of 3, that means colony count of 1000 is significant and 99% probability the child has UTI. If it's a catheter sample, then a colony count of 10 raised to the power of 4 is significant. And if it's a midstream sample, we were always saying 10 raised to the power of 5 is significant. But the recent change which is being made is that the culture of 10 raised to the power of 4 to 10 raised to the power of 5 is significant. And sometimes even the lower colony counts are significant. And the reason is that sometimes the child may have symptoms which are persistent. The child may have taken a course of antibiotics. He may be on diuretics or having polyuria, and we may miss UTI in these children. And so now the recent change we have made is in the culture in midstream urine, 10 raised to the power of 4 to 5 is significant. Bag specimen, I've already said, is not acceptable for culture, and we should not send a culture of the bag specimen. Now, another thing, sometimes you get a report, there's a presence of a positive urine culture, but the child doesn't have any symptoms. Why the culture has been sent in first instance? Sometimes the child is being seen by adult nephrologist or adult physician or gynecologist, an older girl, and all investigations are being done, including urine routine, culture is sent, and it comes positive. The child is otherwise asymptomatic. So this is low virulence E. coli is normally grown, and from clinical point of view, if the child is asymptomatic, no antibiotic treatment should be started for asymptomatic bacteriuria. If we try to eradicate these low virulence E. coli, we may invite high virulence bacteria, which may be more harmful to the child, and we may be doing more harm to the child by treating with antibiotics rather than doing good. So routine cultures should not be performed in asymptomatic children, lest we get trapped with some colony count and we are tempted to start on antibiotics in these children. Now, coming to the treatment proper, once the culture has been sent and the child is having low-grade fever, dysuria, urgency, frequency. So first initial line of empiric therapy, pending the culture report, we can start with oral therapy, no injectable antibiotics, parenteral IV or IM are required. Just simple oral therapy with cephalexin, cefadroxil, or amoxiclav as first-line drug can be started. And trust me, they have got excellent urinary concentration and they can work very well. The duration of therapy, which we were earlier saying was 5 to 7 days, which in recent guidelines has been recommended to be 3 to 5 days, and this is not inferior to 5 to 7 days of treatment. And most of these children would do very well. If the child is older child, you can give 3 days. If it's a younger child, you can give 5 days and just stop it with simple UTI. But sometimes you are faced with a child with complicated UTI or pyelonephritis, what we call, or a neonate where there's high fever, toxicity, or vomiting, renal anger tenderness, or high creatinine. So these are the children where we cannot take a risk with these, and we have to start with third generation cephalosporins or amoxiclav. Either of these can be used as first-line empiric antibiotic therapy in children with febrile UTI. And subsequently, the antibiotic can be modified depending on the sensitivity report. But here I would just like to, because I cannot ask the audience now, what would you like to do? Suppose you have started a child on an antibiotic, say a third generation oral cephalosporin in a febrile child with UTI, And the culture reporters come, and my resident would normally come and say that, sir, this is resistant to cefixime, and the child is sensitive to other blah blah antibiotics, which are all injectable. And once I asked how the child, they said the child is better. The febrile fever has come down. Child has started eating. He's looking better. So what do we do? Do we really need to change the antibiotic because as of the antibiogram? No. If the child clinically is better with whatever drug you have started, please continue with the same medication. You do not need to change the antibiotic if the clinical response has already started coming, and the report may show other antibiotics, but you do not need to change. Now, again, coming to the type of antibiotics in ISPN guidelines on 2011 guidelines, we were saying all these children who are very sick or who are having pyelonephritis or neonate need to go on IV antibiotics, and duration we had recommended was 10 to 14 days. But now the current recommendation is that we should start all these febrile acute UTI with oral antibiotics, except for if the child is not ingesting oral, then of course we cannot give. But other than that, if the child is less than 3 months of age or very severely ill child or septicemic child, there we cannot play around. We need to start with IV antibiotics and then switch on to oral. But all other children who are older children, not very sick but not very sick, and can orally take antibiotics, we do not need to go injectable and start with oral antibiotics in these febrile children. And even if you have started on IV therapy initiated, it may be switched to oral after 3 to 4 days after the fever has subsided and the symptoms are better. Now again, duration of antibiotic here we have cut down from 10 to 14 days to 7 to 10 days of therapy with appropriate antibiotic in all these acute febrile UTIs. And we know the reason, because the antimicrobial resistance is occurring worldwide. And with the shorter therapies, we cut down on the hospital stay, we cut down on the nosocomial infection and emergence of resistance. And all these benefits are there by shorter courses of antibiotics for these children. Now, to summarize the treatment part, if the child is detected to have urinary tract infection and it is confirmed with culture, if it is a lower urinary tract infection, oral antibiotics just for 3 to 5 days are sufficient. If it's pyelonephritis or child less than 3 months, very sick septic child with renal incontinence or poor oral intake, if no, then you can start with oral antibiotics. If all these factors are present, yes, then IV antibiotics for first 2 to 3 days. If child is clinically showing response, yes, then we need to complete the course with oral antibiotics of 7 to 10 days, and that's all. And if the child is not showing a clinical response to IV antibiotics, we should repeat a urine culture and also see for an ultrasound for any anatomical problems, and then switch to another antibiotic after sending the repeat culture. Other supportive treatment, we all know good hydration is helpful. Alkalization of urine is not required with these potent antibiotics. For fever, just stick to paracetamol, avoid NSAIDs in these children. Cranberry, most of the parents would ask whether they can give cranberry. Yes, they can if it is available for prevention of recurrent UTI with normal urinary tract, but for acute febrile UTI, it doesn't have any role. Repeat urine cultures, I would repeat, are not required after completion of the course, lest we again get trapped with a small colony count, and we are not chasing till the last bacterium. Let the body take care of rest of the bacteria. If the child is clinically better, 7 to 10, 5, 7, 10 days, whatever treatment you have chosen is given, just stop it. Unless the child has fever toxicity persisting beyond 72 hours, only then we need to repeat the culture. Otherwise, do not repeat the urine cultures after the treatment course is complete. Now, our role as pediatrician or as nephrologist does not end just by treating the child. We need to see why a sterile urinary tract had infection in first go and what needs to be done now. So there are 3 good tests which need to be done in these children. Not all of them, but we'll see which child requires these tests. One is the ultrasound, which is a very useful invasive, non-invasive test. We would see what is to be seen in ultrasound. We would see for the hydronephrosis, ureteric dilatation, see for bladder wall. Post-void residue is very important in these children. And again, sometimes we need a VCOG voiding cystourethrogram, which can give us an idea about the reflux, about neurogenic bladder, posterior urethral wall, or any other anatomical details. And still with this, we may miss 5% of with ichthyoureteric reflux. Again, third good test is a DMSS scan, which is a static nuclear scan, which is good for seeing the renal scarring. But again, we'll see when it needs to be done and in which child we need to do a DMSS scan. So we were talking about the sonography, ultrasonography, again, very useful, non-invasive, informative. The only thing is that it's an operator dependent, and if you have a good sonologist, half your job can be done by him. But the findings which need to be looked into to see whether the child may have a VUR, if the child has renal hypoplasia, whether unilateral or bilateral, or abnormal echogenicity, hydronephrosis, ureteric dilatation, or bladder abnormalities, we should keep these things in mind for subsequent investigation with VCOG. And this ultrasound should be performed in all children with UTI, whether it is first or recurrent, and we avoid normally in early sepsis or unless early ultrasound in early time, unless the child has got urosepsis or non-responsive or there's a renal dysfunction, then we can do early. Otherwise, we can wait for a little while till the child settles and then we can get an ultrasound, but it is required in all the children. About the VCOG, children who would require, normally it is an invasive test, but all the VCOGs, we do it ourselves and under supervision we do it. And the child is on under antibiotic cover, we do the VCOG, where a thin catheter feeding tube is passed and the bladder is filled with the contrast, where the bladder looks like this. This is a normal bladder. And then the child passes urine and pictures are taken in different positions, right, left, lateral, and oblique pictures are taken. And then we see for any abnormality in these children. And then the abnormality which is detected is sometimes we can see refluxes of various grades, grade 2 reflux, here grade 3 reflux, grade 4 reflux, or extreme grade 5 reflux with a bladder, trabeculated bladder, and the other telltale signs of grade 5 reflux. Then sometimes in younger boys, we see posterior urethral valves here with hugely dilated ureter and bladder with multiple diverticuli, and you can see these bad bladders. And again, a child with posterior urethral valves with dilated posterior urethra with diverticuli and reflux in these bladders. So all this can be picked up with VCOG whenever it is required. Sometimes other anatomical lesion in recurrent UTI, these children with recurrent UTI can have uretroceles, which can be picked up with VCOG, or diverticulum, which can again lead to multiple UTIs. All this information can be taken with the one investigation, that is VCOG. I was talking about the DMSS scan. So this is a static nuclear scan. This is how a normal kidneys look at the DMSS scan, very regular with regular margin and no photopenic areas. This is a normal kidney, and here in this kidney, the child has got scarring at the lower pole, which is showing photopenic areas and lower scarring, unilateral. And this is the child with bilateral scars, multiple moth-eaten appearance, photopenic areas, irregular margins of the kidney, and irregular shape and contracted scarred kidneys. So now it's very important that with these plethora of investigations, which child should have which investigation. If a child is having a first episode of UTI, just get an ultrasound done. If that ultrasound is normal, you can observe the child, no further investigations are required. We were being very aggressive earlier that all these children who are having below 1 year of age, who have even first time UTI, we would go for all the investigations, VCOG as well as a DMS scan. But now we are little conservative. In first episode, get an ultrasound. If it is normal, observe the child. If he is fine, leave the child alone. But if ultrasound is normal with all the findings which I had highlighted earlier, if there's abnormality, then we would need to do a VCOG and see if there's a reflux of grade 3 to 5, then we would need a DMSS scan, but not an early scan. The scan should be done after 3 to 4 months too early a scan can lead to give us a false positive results, but sometimes parents are insisting and a scan is done by someone, then and there are photopenic areas and you are not sure whether they are because of acute infection or scars, then we can repeat a scan after 6 months if we need to be very sure whether they are scars or not. And again, if a child has got recurrent urinary tract infection, recurrent means more than 2 episodes of febrile UTI, or if it's a young child less than 2 years of age and a non-E. coli culture positive or an abnormal ultrasound, these are the children where we would do an ultrasound has already been done. We would need to do a micturating cystourethrogram, and if the child falls into this category, we would need a DMSA scan later on in these children. So very clear that first episode, just follow this line. If it's a recurrent episode or a young child with non-E. coli or abnormal ultrasound, then we follow this track of MCUG and DMSA. But my worry is that as a pediatrician, most of the time you would get children who would have recurrent UTIs, recurrent fevers, haphazardly treated, not investigated properly. And when you see the child, his ultrasound may show abnormalities, or the child may have recurrent UTIs, and you may require to do all these investigation in these children. Now coming to prevention of recurrent UTI, some of the few things, increasing the fluid intake, we all know, but if there's a vesiculouretic reflux, complete emptying of bladder is important. And if there's a post-void residue is more, then frequent voiding or double voiding. Frequent voiding, of course, double voiding means once the child has passed urine, we would tell the mother that make the child wait for a minute or so. Again, the child can sit and some of the urine which is in the bladder which has not been emptied earlier can be passed. Precautions in cleaning of perineal area in girls is very important. And normally I keep a soft toy in my clinic and show them how to clean the perineal area from front to back and hold the child on a wash basin, a small baby, where the water can be poured from top and it can go down, and the perineal area can be saved. So once we tell the mother that the dirty water from the anal area should not enter the perineal area, the mother can understand how to clean the perineal area and she can prevent recurrent UTIs in these children. Again, avoiding constipation is very important. We'll talk about it. Diapers, again, I'm not against diapers, but the way the diapers are used in our hot and humid climate, if the diapers are to be used, then they need to change the diaper every 2 to 3 hours, whether soiled or not soiled, which is not possible in our setup. So it's better to prevent using these diapers very frequently unless the child is going out or for parties or somewhere and they need a diaper for a shorter period, but otherwise avoid using diapers. Otherwise, the child can smudge the diaper with stools and they can again cause unhygienic setting and infections. Circumcision is required in some of these boys with high-grade reflux to prevent UTIs. Management of BBD is very important. We'll see in a minute. And some of these children do require chemoprophylaxis also. We'll see which are these ones. Now, talking about the bladder bowel dysfunction, again, very important that bladder bowel dysfunction means in absence of neurological deficit, there is a problem with the bladder and bowel. And all children with UTI should be evaluated for BBD. Prevalence of BBD is very high in these children with recurrent UTI and with these children with refluxes. So what are the symptoms the bladder would have is these children would have urgency, wetting of pants in daytime, holding maneuvers, hesitancy, frequency, and in the bowel part, they would have constipation, that means less than 3 stools per week, hard stools blocking the toilet, and painful defecation. So if a child has these problems, he needs to be dealt with a specialist consultation where we have to take care of the constipation, take care of the other bladder problems, and these children require antibiotic prophylaxis, and they should be given recurrent UTI till bowel bladder thing is sorted out. So these children would require a consultation with a pediatric nephrologist, usually very difficult to manage, and multiple times we have to counsel them again and again and take care of the constipation and other problems. Now coming to the VUR, Again, some changes which have been made in the treatment of VUR are important. In our ISP guidelines in 2011, we were using antibiotic prophylaxis in all these children with VUR, grade 1 to 5, and blanket we would give it for 5 years, which was very high. So the current recommendations are that antibiotic prophylaxis are not required in a grade 1 to 2 reflux unless the child has got recurrent UTI. Grade 3 is a gray zone, but grade 4 to 5, these children have a high grade reflux, and there they would require antibiotic prophylaxis. And if antibiotic prophylaxis fails, then they need surgical reimplantation also in high grade VUR with recurrent breakthrough febrile UTIs, even on antibiotic prophylaxis. And infants with recurrent febrile UTI, even with sometimes low grade refluxes, we need to give antibiotic prophylaxis in these children. Antibiotic prophylaxis, how long and when can we stop? Not recommended for prevention of UTI with normal urinary tract and absence of bowel bladder dysfunction. Earlier we were saying 1 month we can give, 2 months we can give, but they are actually not to be given, and just take care of the bowel bladder disturbance, and that can sort out the problem. We can discontinue antibiotic prophylaxis in children in older than 2 years of age if they satisfy all these 3 criteria. If they are toilet trained, there is absence of bowel bladder dysfunction, and the child has had no febrile UTI in last preceding 1 year. So suppose the child is 2.5, 3 years old. For last 1 year, he has had no UTI, and he is toilet trained now. You can safely stop antibiotics prophylaxis and watch this child and save him from multiple courses of antibiotics. What drugs to be used in prophylaxis? Again, 2 good drugs are there, cotrimoxazole and nitrofurantoin for prophylaxis in children older than 3 months of age. And in younger children below 3 months, we give cephalexin, and in a very small, tiny dose, 1 single dose at bedtime. Again, a word of caution that NFT should not be used for treatment of acute infection. It has got a very poor tissue penetration. It should be reserved only as a drug for prophylaxis and not for the treatment of infection. Coming to one of the last few slides, how much time is left? Yeah, I have another 2-3 minutes. So a newer phenomena which most of us would be seeing is that in these young girls in schools and during travel, these girls do not take fluids, they do not urinate, and they don't drink fluid. Mostly they are constipated, and various causes of constipating, and that leads to recurrent UTI or UTI-like symptoms. I would say they may not have UTI, but they have UTI-like symptoms of dysuria, lower suprapubic pain. And what is happening in these children, if you test the urine, it would come as normal. You get an ultrasound, and there would be a thickened bladder, irregular bladder, which may be labeled as cystitis by radiologists. But this cystitis is not a radiologist diagnosis. It's a clinical diagnosis, and these children unnecessarily get antibiotics. So this basically is what we call as chemical cystitis, and the treatment is not antibiotics in these children. The treatment is basically that they need to be taught to take fluids regularly, even in school or travel, and keep the bladder empty and use the washrooms. Because of the non-availability or dirty washrooms in schools, these girls are suffering. And my request to all my pediatric friends is that whenever you go as a counselor in the school, please request the principal or the teacher or headmistress that they should have clean toilets for these young girls, lest they get into this problem of chemical cystitis and then later on other problems. Now coming to the winding up, that what are the changes which we have made from 2011 to 2023 guidelines, that in the urine culture, the colony count of 10 raised to the power of 5 has been brought to the 10 raised to the power of 4 to 5 colony forming unit in infants and little younger children. Complicated UTI, we were treating for longer periods, 10 to 14 days. The duration can be cut down to 7 to 10 days. Again, acute phase DMSA we were recommending earlier, but not recommending now. It should be done only after 3 to 4 months. And in late DMSA, again, we were recommending in a child less than 5 years of age, old after first UTI or recurrent UTI and all VURs. But now we are saying only for children with recurrent UTI and higher grade of reflux, we need a late DMSS scan. Then in the again MCUG, we were recommending in all children, younger children in recurrent UTI, but now we are restricting VCOG in children with recurrent UTI, abnormal ultrasound, or a child with non-E. coli UTI. Antibiotic prophylaxis we were giving in all VURs, but now we are restricting to higher grade of VUR, and those children who have BBD, bowel bladder dysfunction, and normal tract, we are now giving till bowel bladder dysfunction is resolved. And again, stopping prophylaxis, we were giving till 5 years, but now in toilet trained child over 2 years of age and no bowel bladder dysfunction and no breakthrough UTI in last 1 year, we can attempt at stopping the antibiotic prophylaxis. Again, surgical intervention, we would say only recurrent breakthrough UTI, and if there's a parental preference that they don't want to give prophylaxis in high-grade reflux, they want a surgery, then we would see, and not in all UTIs, we need surgical intervention. And with this key messages that we should have a high index of suspicion for UTI, urine culture should be properly collected. Febrile UTI carry a high risk of scarring, renal damage, so start antibiotics early, but be judicious. For simple UTI, use simple drugs, use shorter duration of antibiotics. Prophylaxis for recurrent UTI and bowel bladder disturbance and only high-grade UTI, and not in all children is required. Thank you very much for having a patient hearing. And these are my helplines, which can be used any point of time. And I'll be most happy to give any help I can for you. Thank you very much. And I will stop sharing the screen now, and the talk can be open, and comments from experts can be given by Dr. Shashi and Dr. Anuba, and any queries if there are any.
I think Dr. Vasudev, why don't you answer the questions in Q&A? Plenty of them. Some of them we have already answered. But
Yeah.
if you answer that, then we can move on to the
Yeah,
discussion.
I can leave them to the moderator if they would like to. I've already talked quite a bit, so I would leave it to moderator.
Sure.
Yeah.
Sure.
Dr. Shashikaran and Dr. Anuba, you can please take up these questions.
Yes, sir.
Yeah.
Thank you, sir. Yeah, definitely a very comprehensive coverage of the topic, and all the participants are very lucky to have such a simple deliberation on UTI. So, and you have covered each and every aspect, even the modern difficulties in UTI management that they have, like usage of diapers and the urine holding in schools. These are the frequent questions that we get in our OPD practice. Thank you, sir. Now, if we take the questions. So first was, is it just the fever or fever with chills to suspect UTI? So I think you have already answered this question in the initial slide of yours. It's the fever. There is no specification on fevers with chills. Simple fever itself qualifies for UTI. The next question is, do every NNJ case need urine examination? So since I think this question has come up since you had mentioned that jaundice is one of the features, maybe the presenting features of UTI. But definitely, as we all pediatricians know, jaundice can be both physiological and pathological. So definitely you are talking about pathological jaundice only. So it is in the line of management of jaundice, whenever we suspect pathological jaundice, investigation for sepsis is one of the reasons. So I think
prolonged jaundice, right?
This is what you wanted to point out. So
right.
So role of Canberry has already been taken by you in detail. So there was a related question later down: Canberry juice quantity and age. So sir,
Dr. Shashikaran, are you using cranberry in these children?
Sir, definitely no. I'm not using in children. Sir, what I feel is it's more of a supportive, like how we give a supportive therapy. There is no hard found evidence that it will benefit, but there is no harm. So as
Because
I
most
don't
of
use it
these,
very often.
yeah, most of these parents ask, and if they can
Yeah.
procure it, there is only one suspension which is available. Capsules are available, and I know gynecologists are using quite a bit in older ladies for recurrent UTI, where there's no rhyme or reason, and they are actually just using more as a placebo also sometimes.
Placebo.
And but because parents ask, and if you want to give it, if it's available, this doesn't harm, and it may not do any good, but it will not harm.
Yeah. Yes, sir, that's the.
I
Dr.
think that
Shashi,
is
can you
what
please-
ISP guidelines
Yeah.
also.
Yes,
You
please.
have mentioned in guidelines also that the amount of volume that is required for the prophylactic dose of cranberry is huge, and it may be associated with intolerance to such large volumes. So unless it is available, and we pediatrician definitely have the problems with capsules. Most of our younger children don't like to take capsules. So
Great.
next question is DTP. What about DTA? So as sir has already pointed out in the flow chart, so there isn't any role of DTPA in the investigation or initial follow-up. Sir, would you like to elaborate on this? Is there
If
any
permitted,
scenario?
can I elaborate on this, ma'am?
Yeah, sure.
Actually, the DMSA and DTPA, as we always as undergraduates used to remember DMSA, S for structure, and DTPA, P for physiology, for function of the kidneys. So what we are looking out in a recurrent urinary tract infection is whether the previous UTIs or the underlying pathology has caused a significant damage to the kidney. So if it has left a scar, it would be picked up through a DMSA. So what we are trying to find in a recurrent urinary tract infection child is whether it has left a scar. So the appropriate renogram would be to do a DMSA. So if the child has presented much later and has led to a renal dysfunction, and you want to know the functional assessment, then DTPA is recommended. But as far as recurrent UTI evaluation goes, to look out for the scars, DMSA is the preferred mode of renal scanning. So would you like to add anything else?
Right, fine. I think I've already, and we can take up, there are a few more questions.
Yeah,
Yes,
Dr. Shashi can take up the first
yes, sir.
question.
I'll proceed with a few more.
Yeah.
Is there increased risk of UTI in children using diaper? Sir, you have already highlighted about this. The diapers should be used in an appropriate way and for a shorter duration. And if it's used appropriately, we may have to use 8 to 10 diapers in a day. Whether the use of diaper itself will be a etiology for UTI, that we are not sure, but definitely not recommended to be used beyond 2 to 3 hours, or if there is an absolute necessity when they are traveling outside also. So use of diaper is definitely not a recommendation. It is discouraged. Second is, when should you go for MCU or VCU after treating UTI? After how many days? The guideline says minimum of 2 to 3 weeks, because we need to make sure, as it's an invasive procedure, the UTI is completely settled, and then we need to proceed with this. But there are scenarios where a child undergoes a MCU or VCUG on an urgent basis under the cover of an antibiotics, because he has had multiple episodes, and we need to look out or evaluate what is the cost. This is the practical challenge which I have faced in my patients who has had multiple episodes, and it was a male child, and we had to do it under the cover of antibiotics within the stipulated duration of 2 to 3 weeks, and we had to take him up for circumcision. So the guideline says after 2 to 3 weeks after treating an UTI, but situations may arise very less frequently that you may have to do it much earlier, that provided the child is under an antibiotic cover.
And Dr. Shashi, in this, sometimes in boys, we have posterior urethral valves where the
Yes.
child develops UTI, and there we have to do an MCU earlier to rule
Earlier.
out, and fulguration of valves is required. So there are situations where we need to do it earlier, but in general, as you have suggested.
Yes.
Sir, I would like to add one school of thought ISPIN also is that we need to do MCO or VCUG as soon as we complete antibiotic. But is there any scenario when we can get it done even while on antibiotic?
See, what I normally do is that the child is to be on antibiotic for 7 to 10 days and the child fever has subsided and we know that this is required, the child had recurrent UTI or some telltale signs on the ultrasound, then at the end of the antibiotic course, I would do an MCOG so that I do not have to restart the antibiotic. And most of the times we are doing it safely without any problem. But if these parents sometimes want to buy some time and they are not ready, then we would put the child off antibiotics. And again, at the time of MCU, we have to give a single shot of either injectable antibiotic or amoxiclav 2 hours before the procedure so that the child does not pick up infection because of the procedure.
Yes, sir. So we'll proceed with next, sir.
Yes, please continue.
Okay. Delayed voiding by school students for lack of clean washrooms. Yeah, you very rightly put it up in the last one of the last but one slide about the chemical cystitis that has been clearly addressed in that particular slide, sir. Next, there is antibiotic prophylaxis duration in CACOT. By mean CACOT, if they are meaning BUR, sir, you have already addressed it. If there is a grade 1 and grade 2 VR, we usually don't give antibiotic prophylaxis, but a high grade VR definitely requires antibiotics. And if the child has been started on antibiotics, we should also know when to stop it. As suggested in the guidelines, if the child is toilet trained and has not had a UTI in the last 1 year, that is the moment probably when we will think of taking the child off antibiotic prophylaxis. And if there are if there is any situation which demands the corrective surgery is required, then antibiotic prophylaxis will be stopped after the corrective surgery. Then following up with a few more questions, cranberry juice quantity and age has been addressed. How frequency to do a VCUG on children on prophylaxis? VCUG is a invasive procedure with a high radiation exposure. Generally, it's not recommended to repeat VCUG on multiple occasions. If needed, cystogram is which is usually done. So the recommendation for a repeat VCUG once the diagnosis is made is not necessary. Do we need to switch antibiotic prophylaxis or only one antibiotics will suffice? Yeah, this is what is the question about cycling our antibiotic cycles to avoid resistance development. In this regard, if you ask me personally, I usually don't do it, sir, because I usually take them off antibiotic prophylaxis at the earliest possible time, provided the other factors are mentioned. Sir, if you have the experience in switching antibiotic prophylaxis, please.
We don't. Our surgery colleagues are normally pediatric surgeons sometimes do it, but we don't encourage that switch. And if a child is going well on NFT or cotrimoxazole, I would continue that. And even if the child has a breakthrough infection on prophylaxis, we can restart the same prophylaxis, not necessarily that we need to change, but we don't need to cycle it if the child is keeping well.
Yeah, yes. What is the age of surgical therapy if a child has UTI even after stopping prophylaxis? Surgical therapy for VUR, reimplantation is what I believe the question is addressed to. Even after stopping prophylaxis, so I understand it by the child is on continuous antibiotic prophylaxis, there is a breakthrough UTI and a severe high-grade VUR. If that is the question, then as the guideline suggests, the surgery would be the way to go if the child has a breakthrough UTI in spite of antibiotic prophylaxis. If I understand the question in another way, that means the child has attained all the satisfying criteria that does not have a UTI in the last 1 year, has been toilet trained, and then there is an episode of UTI. Then probably we will have to reevaluate the child whether it really requires surgical therapy and then we have to go ahead. That's what I could understand from this question. Then why deterioration in renal function is not considered as an indication for surgical intervention in your guidelines? There is one of the indications for surgical intervention is appearance of new scars. So appearance of a new renal scar on a repeat renogram, if you have done, is an indication for surgical guidelines. Correct me if I'm wrong, sir.
Right. I think if there's a slight deterioration, that doesn't mean that by doing a reimplantation, we can prevent that.
Correct.
Because once the scar has already started and there's dysplasia, the surgery or no surgery or only prophylaxis, this will not make any difference. And there have been long-term studies where prophylaxis has been given, vis-a-vis surgery has been done, and at the end of 5 years, 10 years, the quantum of scars or the changes in the scars have not been different. So surgery will not necessarily prevent scarring, but yes, if there are new scars appearing, that means probably the damage may increase further, and then surgery may be indication.
I would like to reiterate here, sir, that just because a child has undergone a surgery doesn't mean the long-term outcome of the child would improve, because whatever the damages occurred has already occurred. So if there is one surgery which usually has proven benefits in various randomized control trials is circumcision in males, that too with respect to further episodes of UTI get controlled, not with respect to the long-term renal outcome. In constipated child, how to suspect UTI? When should we investigate? A child who is constipated has a very high likelihood that he has an episode of UTI or a recurrent episode of UTI, or vice versa. A child who is presenting to us with multiple episodes of UTI needs to be evaluated for if there is any presence of constipation. If such a scenario is there, we may have to proceed with the proper history taking, including like certain retention maneuvers. Habitual constipation is very common in 3 to 6 year olds. So that we need to evaluate first, and then proceed with detailed evaluation to look out for bowel bladder dysfunction. As sir had rightly put in a slide, where there is no obvious neurological involvement, but there is features of recurrent UTI and a constipated child where we have to look out for bowel bladder dysfunction.
Dr. Anubha, would you like to take some of these next questions?
So in this same, I would like, I think this, to suspect UTI in a constipated child, the parameters remain the same to simplify the things. Only thing you need to have a higher index of suspicion to look for any urinary tract abnormalities. Otherwise, the criteria remains all the same for a constipated and non-constipated child. Now coming to role of cefixime in UTI, as sir has already told, the third generation cephalosporins are the first line drugs. So basically we go for cefadroxil and cephalexin. And so those are the preferred drugs for treatment. How to differentiate cystitis for chemical cystitis? So this sir has also already answered in his presentation. Chemical cystitis is one that is due to various behavioral holding, urine holding, dirty washrooms, all these, due to these conditions, the girls are not able to void and have a proper bladder habit. So those lead to a radiological diagnosis of cystitis, which is actually not microbiological cystitis. So this is what is the difference.
And even the urine examination in these children would be normal, and they would have a typical suprapubic pain and discomfort and dysuria, but there is no UTI, no telltale signs of UTI biochemically also. Right. Next one, what is that?
MCUG is advised in recurrent UTI until what age? So MCUG is advised only if we have an abnormal ultrasound, because whenever there is a recurrent UTI, so even for the first episode, we go for an ultrasound, and only when the ultrasound is abnormal, then we go for MCUG. So whenever we have a second episode, because at the second episode, it is labeled as recurrent UTI. So I think so whatever age it may be, we need to proceed stepwise, first with an ultrasound and then with MCUG if there is abnormality with the ultrasound. Until what age is the risk of scarring in kidneys? I think this question is asked in reference to VUR. So VUR has even higher grades of VUR has a tendency of spontaneous resolution. So once it resolves, the tendency of scarring goes down. So it is only till the persistence of VUR that there is a tendency of further scarring and renal parenchymal damage. So would you like to add something to
Yeah,
it?
Dr. Shashi, anything more?
Nothing much, sir. There is, as such, we are not sure at what age is this scarring more common. Rather, I would say the earlier, the higher the risk.
Right.
As you had said, it is not just the UTI that's produced scarring. There are multiple other factors, a complex papilla, back pressure, and multiple theories and hypotheses goes behind the cause for scarring. So the earlier episodes are the one which carries the higher risk for scarring. That is what I would like to add on it, sir. If you would permit, we'll
Right.
proceed further, sir.
Yeah.
Do
yeah,
we need
please.
3 consecutive days urine sample or single morning is enough? Single morning sample is sufficient for a urinary tract infection diagnosis. The 3 consecutive sample evaluation is for a nephrotic syndrome proteinuria evaluation. So do we need to do a urine culture before doing VCUG on a child who is on prophylaxis for recurrent UTI? The recommendation is if the VCUG is usually done after episode of UTI is adequately treated. Yes, it is an invasive procedure. So a urine culture which is sterile is necessary that before we do this invasive procedure. When to do MCUG in acute phase or later? We have addressed this already. When do we do VCUG after diagnosis of VITA? I mean, time interval from diagnosis has been addressed. Duration of prophylaxis is started at 1.5 years. The duration of antibiotics we have already discussed. At least the child should be without any episode of UTI for past 1 year. So if you have started 1.5 year, the child will at least receive for up to 2.5 years of age. Provided there is the 3 criteria which we have already discussed are met, we will be stopping antibiotic prophylaxis. Class keep in YouTube, please. Okay. All right. I will be uploaded. Okay. Your experience on cutoff line for creatinine and urea, where we need to be a bit conscious at peripheral age-wise. So would you like to highlight on this? What would be the cutoff limit for urea and creatinine?
We need to do a bit. Cutoff means the normal. Normal are different. They depend on the lab to lab, and each lab will have the way the urea creatinine are done chemically. They would have their cutoff levels, and we need to see that, which is important, because some of these labs will have a creatinine of 1.0, another will have up to 1.5 or 1.8 also. So depending upon the lab to lab, they would give us the along with the report, they would also give us the normative report also. And some of these good labs, at least I've seen that they give age-wise also, that depending upon the age of the child and adult, we can have cutoff values depending upon their laboratory procedures.
Next one is a case if a child having UTI symptoms with fever and is the first contact of the child with medical facility and we are very sure it's UTI, then should antibiotic be started right away or first contact, or should we wait for routine and cultures and the child should be sent home with paracetamol and supportive management only and wait for reports? This is one thing which we should try to avoid. Right away starting antibiotics is not in good lines with antibiotic stewardship. So as sir had said, nowadays we have a dipstick, which is a very simple test with 3 parameters. If you can look into leukocyte esterase, nitrate, and sometimes if you can on a microscopy pick up some bacteria and a gram stain, it is very close enough to say it is probably we are dealing with UTI. Having said that, we need to develop the culture of sending a culture. So send a culture and then probably if the 3 criteria which I told on dipstick is met, you can start an antibiotics and revise the antibiotics once the culture is available. So assuming that it is UTI for any fever and may not be, we are missing an opportunity to identify an underlying acute. This was very well described by Sir in his first case, how the child ultimately landed up in a chronic kidney disease. So I would recommend at least to do a dipstick and send a culture, then start an antibiotics.
Dr.
So
Anubha,
if a
can you
child,
take up the next? Sorry.
I would like to add, because in our scenario, we get a lot of patients from the rural background who never turn up once they have shown come to the OPD. So here, as I would echo my thoughts with Dr. Shashi Kiran, that definitely the rampant use of antibiotic is against the antibiotic stewardship. But one thing, if you are sending off the patient, here one thing that needs to be highlighted, especially for the postgraduates, that you need to sample the patient before you give even the first dose of antibiotic. And it is on your part. It is important to emphasize the importance of follow-up if you are not giving an antibiotic. But if you are sure, because many times when we are seeing these patients, we are sure that they are so reluctant of coming back. So I think it's better to treat than letting them go off with a die, because I don't know what Dr. Saif wants to highlight. If he says that if we are very sure it's UTI, so if they are very sure, I think they have already done a screening test, and that is otherwise clinically, with, as Sir pointed out, only with clinical features, they are so overlapping with so many other diseases, especially in younger children. It is difficult to be very sure if it is UTI. So supposing that you have already done a screening test and you are suspecting a UTI, I would say it will be better to send the samples, start an antibiotic, and try to convince them to come for a follow-up. Sir, would you like to add?
There's another question on antibiotic prophylaxis. Next one.
The child is on antibiotic prophylaxis during first breakthrough UTI after on antibiotic prophylaxis. Should we add another antibiotic along with prophylactic antibiotic? So as Sir, you have pointed out, the antibiotics for prophylaxis and for treatment are different. In prophylaxis, we prefer nitrofurantoin and cefixime. But the set of antibiotics we give for treatment are different, and the doses are different. So we definitely need to hike up on the doses if we are going for treatment. So the treatment should be as treatment per se, and we cannot just there is no scope of adding on. It has to be the antibiotics of therapy only. Older children around,
yeah, please carry on.
yes sir. Older children around age of 10 or more coming with first episode of UTI, do they need USG if responding well to treatment on OPD basis? Definitely. Even as Sir has pointed out in his flow chart, even the first episode of UTI needs to be investigated at least with an ultrasonography, and to be followed up if there is any radiological abnormality on the sonography. So whatever, irrespective of the age, even the first episode of UTI needs to be investigated.
This is a little technically difficult question. Dr. Kinikar has asked, Aarti Kinikar, 6-year-old with 18% functioning kidney with grade 5 VUR same side. The other kidney is normal. 2 episodes of UTI. Is nephrectomy or affected kidney or any other option? Please guide. See, if in these cases with 18% function, less than 20% function is very, very meekly functioning kidney, and the child has got grade 5 VUR. First thing is whether grade 5 VUR has been operated upon and an anti-reflux surgery has already been done. And despite that, if the kidney functioning is going down, probably we cannot do much for them. And I would say if the blood pressure of the child is normal, the child doesn't have proteinuria, the growth is not being hampered, and kidney is not troubling us with the recurrent UTIs, then we would not like to remove the kidneys just for the sake of removal. But on the other hand, if this child has got recurrent UTIs and there's hypertension and there are other telltale signs that there's deterioration in the function, then of course there's the only option is that we have to do a surgical nephrectomy in these children. Dr. Shashi, any other, Dr. Anubha, any other opinion on this? I think these
Yeah,
are
I-
the difficult cases. Dr. Alok, your mic is on. Dr. Alok, your mic is on.
I might end up needing.
तो अभी तो I think meeting is ending कि नहीं?
I think there are a
That's it's
couple of
almost over.
Yeah.
So we had a very good, great interaction and interactive session, and lot of things have been sorted out. And Dr. Dr. Vasudev, you were also missed. आज renal case था आपके वहां से निकलते ही उसमें the people were looking for you at AIMS.
I had to attend an emergency case, so they was waiting for in the hospital. So I had to rush to the hospital and see the cases there. I know.
अच्छा.
So anyway, so I think I've already put up my number and email ID in case there are any more queries, questions. All of us are available. Dr. Shashikiran also is available. Dr. Anuba is available, and I am also available. And we can answer the queries. If there is time, we can go ahead. If there is no time, then I think we'll have to stop as per the what is the guidelines from the organizers. Whether we can, there are a couple of 2-3 more questions. I think if you want, they can be taken up by the experts here.
I think Anand, you should take it up at a personal level now because we already crossed nearly 15-20 minutes over time.
Right.
So
But this has been heartening that we had a good attendance and a lot of questions, queries. That means our audience is really keen in knowing, learning, and also asking and also clearing their doubts. So this was excellent, and I would again thank my moderator, Dr. Shashikiran, and Dr. Anuba, also our chairperson, for being with us and also answering all the queries. And over to the organizers.
thank you very much, Dr. Alok Bhandari. Any comments or?
No, sir, no, it's good, but I just wanted to remind all the attendees that Delhi, this list of membership is freezing on 31st of July, and from 1st August, there will be an increase in the membership fee. So all those who are not members of IAP must become members of IAP, and all those senior residents and young faculty who had become members during post-graduation should send their degree copy, and so that their membership is converted from associate to full life membership. Same way, students have to send their qualification proof so that they are converted from student to life members. So for new members, the membership fee is increasing. That is why they should send it, and others should take the benefit of updation of database effort of central IAP and help in organizing the data. So, and all those whose email ID and mobile numbers are not correct may do so at the earliest. And this is opportunity for next 10 days or so. And
Thank
at
you.
Delhi level, everybody should enroll for PCNI, which is our flagship program, Pediatric Conference of North India. Okay. Sir.
Thank you very much, Dr. Alok. Thank you, Anand. Thank you, the chairpersons and the moderator. An excellent talk. One of the talks which has got the maximum coverage. Once again, thank you and good night, everybody.
Thank you. Thank you very
sir.
much.
Good night,
Thank
sir.
you, Dr. Shashi, and thank you, Anuba.
Thank you,
very
sir.
much.